there we were at the Kalahari Resort, me and Remle and Dr. CJ Winkler. We were going to have this great, and we did, as a matter of fact, had this great intro to this episode where Remle describes a normal histogram and CJ sees a violin plot, and he has some rather interesting thoughts about, maybe a Rorschach test, about what he was seeing in that plot. And it got a little spicy even for this podcast, so I had to cut that out. Instead, what I'm going to do is read a very helpful message from our friends at ChatGPT. As you will find out when you get into this episode, the three of us are going to talk about Bayesian analysis, and it can get kind of complicated. It can be a little difficult to understand. We give 2 examples in that, but I think ChatGPT gives us the best example ever, especially for me and CJ. So I'd like to read that to you. So the prompt I gave ChatGPT was explain Bayesian analysis to me like I'm an East Texas redneck. Now, as it turns out, that's really helpful because me and CJ are both rednecks from East Texas, so it helps. So ChatGPT says, well, howdy there. Imagine you're out hunting for the biggest buck in all of East Texas. Now, before you ever head out, you might have some ideas about what their big old buck might be. That's like having some initial beliefs about where to find the deer. Now, as you start looking around, you see some tracks and some signs. Each new piece of evidence, like them their tracks, gives you more information about where that deer might be. Bayesian analysis, well, it's like taking them initial beliefs you had and updating them based on each new piece of evidence you find. So if you start thinking the deer was near the watering hole, but then you find tracks leading to a different area, well, you just might change your mind and think the deer is somewhere else. It's all about updating your beliefs as you gather more information, just like adjusting your hunting strategy based on what you find. Now, as it turns out, I think that is one of the best descriptions of Bayesian analysis I've come across. It certainly beats the 2 descriptions that Remle and I used. So, this is a serious episode about Bayesian analysis with 3 very unserious people, as usual. Hope this information, just think about this example when we're talking about jelly beans.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of clinical practice. We're going to shine a little light with 2 of my good friends here. I think y'all know Dr. Remle Crowe. By some complete act of negligence on my part, we have not had Dr. CJ Winkler, paramedic, ER doc, EMS doc, on our podcast. CJ, welcome.
Thank you. You forgot firefighter.
I did forget firefighter. That is a terrible thing. I just assumed that because your background was with Austin EMS, that was not on your resume. I apologize.
That's okay. I'm a fake firefighter. I just did the training and got my certification, but just by training.
Well, at least you got it.
Not by practice.
At least you got it.
Paper firefighter.
That
Paper
seems
firefighter.
like a bad combination. I mean, I'm not a firefighter, but I've seen a lot of paper burn. That's probably not what you want bunker gear made out of.
Yeah, mostly I'm just a paramedic. You're right. That became a doc.
I like it. It's props to us. Yes. All right, guys, let's talk RSI. CJ, I got a scenario for you.
Let's go.
All right, there you were in the field. Got it?
True story.
Okay, you've been there. You have a 63-year-old male, basically otherwise healthy, No real problems that we know of. He's been running a fever for the past 3 days. He's been coughing up this stuff that just looks nasty. He's been more and more short of breath. He got some albuterol from his wife, used that, not surprisingly, didn't help. He finally got to the point where he just couldn't take care of himself anymore. He is speaking like 1 to 2 word sentences, and that's what he tells dispatch. They send you, you show up. You find him looking a little confused. He is he's altered, and his blood pressure is about 101 over, say, 70. His heart rate is 120, and he does have a temperature. His temperature is 101, let's say. And he's febrile, and his respiratory rate is 32. Entitled CO2, I don't know, we'll call it 35, just to make things easy. You take one look at him and say, you're not going to protect your airway well. We need to, I probably ought to tell you his oxygen saturation. It sucks. It's bad. Let's call it 65.
That's not good.
No, that is, I believe the statistical term is low.
Sounds about right.
Low. So you determine that you're going to take his airway, and you have RSI. You have all of the drugs for RSI. And let's say you're going to use rocuronium, because that ain't what this podcast is about. What sedative agent are you going to use for this person? You got any sedative agent you want.
Yeah, so great question. I'm glad you asked what sedative agent I was going to use, because I'm worried I might have said he needs a Bayesian meta-analysis right now, immediately.
But look at CJ jumping
saves
ahead.
lives.
Bayes. It's all, what's it all about, Remle? It's all about that Bayes. Thank you.
That could be the theme song. Oh, no tappy tappy.
No, that was strategic tappy.
Oh.
Strategic tappy. So that was a great segue. What drug are you going to use, Doc?
Well, one of the drugs I would like to use if his SAT 65 is how about we get his oxygen sat up with oxygen,
I'll tell you,
and maybe we
question.
can give him, high flow nasal cannula. I really don't like to put positive pressure on these folks, but that's not the question you asked.
No, it wasn't.
His blood pressure is okay-ish, so I think we can deal with that. But I do like to put a lot of oxygen in these folks before I RSI them. But in the spirit of keeping this down to 20 minutes, we'll say I think my personal drug of choice would be ketamine for sedation in this patient.
So I like the fact that you said you want to get some oxygen on him. You try. Let's say you want to put a nasal cannula in underneath perhaps a non-rebreather. He is having exactly none of that. He is altered. He is pushing it off. What you going to do now, doctor?
Yeah. So this guy's in imminent cardiovascular collapse. You are in a catch-22 of Joseph Heller proportions that can't be fixed, and
Look
you
at the
absolutely
yes, nice literary reference. Not bad for an East Texas redneck.
Oh my!
Between you and me, we've read all the books in Southeast Texas.
That's right, both of them.
So that's a very difficult patient and a real world patient, and you feel bad for the patient, you feel bad for the medic that has to treat this patient in real time, and there's no winning, right? This patient's going to go into cardiac arrest or respiratory arrest. So I'm going to apply the ketamine. If you're able to get an IO on this patient, sounds like you wouldn't tolerate
got access.
it. Okay, perfect.
You got
yeah.
access.
Let's go ahead and give ketamine 1 to 2 milligrams kilogram and go with that. Ketamine's my choice because there's respiratory wise, this at least colloquially, respiratory wise, I think it's going to be better. Yeah, they say it's better than Versed. And actually, in my shop, not too long ago, I went to ER residency. We only had propofol.
Oh my gosh! So propofol, I love propofol. Milk of amnesia here. Why wouldn't you want to use propofol for this patient to induce them?
Well, classically taught by they. It's also
and experienced by me.
It does cause cardiovascular depression.
Yeah, it'll drop that blood pressure.
Yep.
All right. So you mentioned midazolam. I think most of our folks who are using midazolam or thinking about, or those other systems, let's go with those other systems,
right,
that use midazolam use an unbelievably low dose. So they'll use 2.5, and they're off by about a factor of 10. So the induction dose is 0.3. I mean, how many people do you know, paramedics, who would be willing to push 20 milligrams, 30 milligrams of Midaz for an RSI that say, oh, hell no, I'd drop their blood pressure?
Yeah, you bring up the real point. And of course, because it's your podcast and you've thought about this, the real point
for
is
at least 20 minutes.
The real point is that we underdose Versed in EMS because we don't use it quite for this indication.
Absolutely.
And in the ER, when you're going to use a medicine, classically, generally it's going to be Etomidate, which is also 20 or 30 milligrams.
Yes.
Which is what the same dose of Versed should be. So it's always surprising when the paramedics hear, look, it's not 5 milligrams. You say 10 milligrams, and then you're going into uncharted territory mentally for these paramedics.
Oh my God,
but you're like,
give
no,
IM of 10 for a seizure? I don't know if I can do that.
Yeah, you're like, the problem's already happening. Let's fix the problem. So the 20 milligrams of Versed, I agree. That's my start dose for Versed.
So we're going to do, let's just assume we're going to do an RSI for this scenario, because we've narrowed it down to ketamine and etomidate. Those are the most likely agents, most common agents. Propofol, it's going to have huge hemodynamic effects in this situation. You already got a dude whose shock index is, substantially above 1. This is a danger zone. We're not going to use midazolam, so ketamine versus etomidate. We'll exclude DSI from this perspective because you really need ketamine. So RSI. So you're going to go with ketamine. I like that. Do your medics in San Antonio do RSI?
Some select medics do. We have a medical special operations unit, which is 2 ambulances, about 20 paramedics, and they actually get extra training every month by the EMS fellows or by me, and they all have to be signed off. It really...
So what do they use?
I'm sure this podcast has mentioned many times how difficult it is to train 1,500 people to do RSI,
absolutely.
Let alone one intern in the ER.
I'm not sure which of those two things is harder, to be honest. But so, which what drugs do y'all use?
We have a lot of drugs, but generally what we use
for this purpose.
For this purpose, we have a lot of drugs for this purpose, Dr. Jarvis.
So there are choices involved.
We have. We have ketamine.
Okay.
We have rock. We have Versed, and we have Sux.
So eliminate rock and Sux.
We actually have VEC as well.
Okay. Well, let's eliminate that too, because I just want to talk about. Eventually, I'm going to get to this paper, which is about the sedative agent. Do they use Midaz for RSI, for sedation, prior to the paralytic?
They can use Versed, but generally we use ketamine and rock. And since it's fellow firefighter paramedics, we call it K-Rock 100.
K-Rock, baby, yep.
Technically,
100 and 100?
Yeah, 100 and 100. Technically, my EMS fellows have a little bit of a heart attack because they get to be purists. I don't know if you've met EMS fellows.
Never.
They constantly tell me.
I'm an old guy, right? I grandfathered.
They constantly tell me I'm underdosing my ketamine, which is probably true. But I'm like, my goal, and my rock, and my goal is to get them to remember. To try to get it right in real time.
Alternatively use the checklist, or at least say
we do have a checklist with the correct numbers.
So let's talk. Let's try to. Our clinical question here is: we use rock. We got a patient that clearly needs to be intubated, and is on the edge of hemodynamic stability. So blood pressure, technically, it's above 100, but not much. But his heart rate is substantially above 100, giving a shock index of above 1. And we know above 0.9, we start to get really nervous, and they're at high risk for hypotension. We also know that the number one adverse event around the peri-intubation period is hemodynamic instability. So about 80%, there's a great paper on this. There was a systematic review and meta-analysis, 29 different countries, and they looked in hospital, and they said 48% of patients had an adverse event, major adverse event in the peri-intubation period. 80% of those were related to blood pressure. Now, as somebody who's been preaching the dangers of peri-intubation hypoxia, I was pleased that was only around 10%. But blood pressure is a problem. So there's this big debate going on about whether you use ketamine or etomidate. What's the difference in mortality? Which causes more changes to the blood pressure? So the paper we want to talk about, because we are going to get to this. Oh, crap. You know what? What the hell? I just realized this. We got in the video, we have an elephant and a giraffe. The giraffe's just for you, Joelle. So where are we? What are we doing here?
Oh, I thought this was like, would you intubate this
What
giraffe?
size tube do you need?
I thought that
Yeah.
we were having some.
How many cervical vertebrae does that giraffe have?
I don't know. I believe giraffe has a larger heart than an elephant. Is that? Can anyone verify?
I'm not that kind
We're
of
going to put
doctor.
that in the show notes. I think that's where
if I
things
want
go.
to intubate this elephant, do I
Yeah,
intubate
I wouldn't
here?
know. I
that's
don't
his
believe.
nose.
I think that is a nose. We don't do nasotracheal intubation in elephants. How many cervical vertebrae does the giraffe have? Does that large mammal have?
The same number as a human.
Yes, because a mammal is a mammal. He's got 7 too. They're big ass vertebrae. But anyway, so let's talk ketamine versus. Damn it, y'all
Did we say why
not
we're here?
know.
What are we
Look,
doing
we're
here?
at we are
We
at
don't know,
a conference, and we
clearly.
got to plug the conference. We're at the Kalahari Resort in Round Rock, Texas, in Williamson County, I might add, and we are at the 5th annual Texas chapter of NAMSP conference. So this is number 5. There are a ton of people here, way more than like the 20 we all had crammed into the
Ghost Hotel.
historic hotel in Menger Hotel in San Antonio. Great conference. Really glad to
Honestly,
to be
my
back here.
my favorite conference of the year. I'm not just saying that. This is when I see the people that have the same issues as me. Not just me and Remle, the other people that have other
That's not
EMS.
when you get checked into that other location.
Right? Well, true. We have those, but we're among our people here.
Yeah, these are our people.
So you may have been to some conferences where there are medical director panels where medical directors sit up at the front and take questions from the audience. Almost everybody here is a medical director, or our professional members are associated with the Office of Medical Director, meaning helping us get the things done. So
Or
the
there's me.
question,
Or they
for
do
the
research for EMS.
You help us get stuff done, like trying to figure out how to make clinical decisions. So the questions for the panel aren't questions for the panel; they're questions for the audience, and
Right.
that's how we run it. All right. Great conference come. So Emily, Dr. Emily Kidd, Dr. Kevin Schultz, Juan, all did amazing jobs organizing this conference. Best ever. Great job, Slotted Group, to put this conference on. Let's talk some research. So the paper we're going to talk about today to help us answer this question, ketamine or etomidate, is ketamine versus etomidate as an induction agent for tracheal intubation in critically ill adults. Wait for it, there's a colon. A Bayesian meta-analysis. This was in Critical Care, just hot off the presses, February 17th, 2024. It was by doctors Kuroki
BMC
et
critical
al.
care.
BMC, yes, open access.
Yes, freely available.
BMC, yeah. And you're right. I am just reading this, and I just did hey, give me the citation, and you are absolutely right. Too many critical care journals. There is, by the way, an editorial associated with this that talks about pragmatic application of this. Take a look if you want to. So let's run through the methods real quick. That Bayesian analysis thing, where it's all about the Bayes, I want to ask you, Remle, what that is in just a second. So let's go over the methods, and then I'm going to jump into it. This is systematic review and meta-analysis. We've talked about this before. A systematic review is where you go out in a very systematic and organized fashion, looking at all sorts of indices for papers. You get those papers, and then you go through to make sure that they have the ability to answer the question you want, and then you group all of that data together from your abstracted data, and theoretically, you can get a more powerful answer than any one paper put together. Powerful meaning statistically anyway. So they looked at all literature that was published up to April 27th, 2023. That was their drop dead date. They limited these papers, not just to case studies. Nope, out. We're not looking at those. We don't want any observational studies, asterisks. We want randomized controlled trials, or if you're going to do an observational trial, they will allow for propensity matching when done correctly. Same data set, equal opportunity to get the intervention. So that's the limitation. When we typically think about a study, we're going to get a p-value. right? So in order to get a p-value, you have to be of the statistical tribe known as a frequentist. Now, not everybody is among that tribe. The other tribe, you have your frequentist on one side. Those are the p-value peoples. And then you have the Bayesians, which is the Bayesians think this ain't a black and white world, baby. I want to know probability. Can you talk to us a little bit, Remle, about the difference between Bayesian analysis and a frequentist approach to statistics?
You're going to deprive CJ of this opportunity?
You're right. I am so sorry, CJ. We were at the bar last night, as we frequently are, and sadly, we were not at the bar last night.
Yeah, I was on call.
It was an oversight, and I won't be there tonight because, damn it, I'm on call. So what is this Bayesian analysis? Because you were telling me how much you wanted to answer this question.
I thought that was the one.
So we're not going to get a drink together at this conference, like two ships passing in the night. I'm sorry, but that's when most of our good research talk happens.
I like non-alcoholic beer, so I'll have one of those.
Oh, that sounds terrible. So, well, I think after reading this paper, I think I'm a Bay fan.
Yeah.
A Bay or Bays?
Bays.
No, yeah, I know, but it's like I was trying to throw in the Beyonce. I was trying to throw in the Beyonce.
Oh.
Good reference.
Sorry, I'm not with very hip people, but
no, definitely not.
So
you clearly met me.
I mean, basically, I've said this to you many times. The frequentists, as I did not know they were called until you just told me.
Most people just call them statisticians.
Yeah. Well, I mean, the P less than 0.05, right? It has to be 95% or we throw it in the trash can. I've always had a little issue with that. What about 90? What about, 94%? Why can't we have 94%?
You could make a 94% confidence interval, but that's not your p-value.
Yeah, well, confidence interval. Thank you for helping me out. But I think that the spirit of what I'm saying...
My job here is done. Go for it.
I think the spirit of what I'm saying is that, what if something is 83%?
So what if perhaps, I'll throw you a line here, what if your p-value is 0.51?
Well, that's not very helpful.
It's not, right? So we're told that something is either statistically significant or it's not, right?
Right.
And you're saying, this is far too rigid for me. You're not about that.
It doesn't seem like a real... It's probably very important if building a bridge or a rocket ship. You probably want a p-value of 0.00001.
They definitely don't use 0.05 as
but
the cutoff.
No, these are people. These are people.
The physicists look at medicine and go, "Oh, that's one of those soft
like,
sciences."
So
well, there is a group, the lab folks, that probably are look at regular medicine and think that we're a little bit outside with the 0.05 as well.
Yeah, maybe. But what if I just reject the entire notion that you can take a question and generate a dichotomous answer? It is either yes or no. The world, Dr. Crowe, as you know, is black or it's white. It's white or it's black. There is no gray.
Well, I am not a 0.05 level person, fortunately.
Look at that.
But I asked before we came down, I asked ChatGPT if they would explain to me, like I was CJ, what is Bayesian analysis?
Well, good luck. So they can go down. They can go down to Labrador Retriever level. That's amazing. ChatGPT is truly amazing.
Let's talk about it and see if it worked. We got to test this. So, as a scientist, I wanted, for science' sake, I'm going to give you the ChatGPT explanation.
Good.
Why not?
Let me know.
So ChatGPT says, imagine this, CJ. We've got a jar, and in this jar, it's not a mason jar. It's a solid black jar. You can't see inside it. But in the jar, I tell you,
it's a jar that Schrodinger would like.
It's Schrodinger's jar.
This is Schrodinger's cat right here.
There it is, but there's jelly beans. It's not. It's
so
Schrodinger's jelly beans.
Nothing's going to be dead inside.
No.
Okay.
Just there's delicious jelly beans.
Have you ever tried to resuscitate a jelly bean? I mean, we don't know.
There's some jelly beans in there, and I tell you that some of those jelly beans are blue, and if you can tell me how many blue jelly beans in there, something great happens. Okay, but so your first thing, tell me how many blue jelly beans are in the jar. Okay, you're going to tell me a number, right? But then imagine you have this magic device. This device is Bayes, and you put it on top of the jar, and the device allows your friend to look in the jar. And there's a bunch of jelly beans in there, and your friend gives you a guess. So are you going to update your guess now that you have that information? I give you another chance. Tell me how many jelly beans, blue, are in the jar.
For example, your friend says higher, lower?
Yeah, your friend says there's 10 blue jelly beans in the jar. Are you going to update your guess based on that?
Yeah, well, of course.
Okay. Well, it wasn't quite right. It wasn't quite the truth, but Bayes is going to give your friend another look in the jar. Your friend takes another look. All right. I think it's 13.
Your friend is fallible. They don't count very well.
Your friend has some trouble with the numbers. But, okay, well, you know what? They took out some of the other jelly beans that weren't blue, and now your friend got a better look, and they said, actually, it's 13 now. Are you going to update your guess?
Okay. Yeah, of course.
Okay, he does. All right, well, one more time. Bays gives you another look in the jar, but they took out some of the other jelly beans that were in there. You know what? It's 26. All right, you update your guess. We dump out all the jelly beans. It was 26.
So, I mean, I guess my first response is when you use ChatGPT and Dr. Winkler to look up Bayesian,
I didn't put doctor.
It put jelly beans in there.
It said Dr. Winkler.
You know, I am wearing my university professor
Thank God it says
uniform
UT.
right now. Whew, oh.
Yeah. So the jelly beans are important, and
Right.
all Bayes is allowing us to update our best guess based on what we've already learned. Frequentist would have been like you saw the jar new every single time, and nobody got to look inside it and give you any information.
So, for example, let me ask you this because you're a firefighter. Is it possible
Fake firefighter.
for something to be actively combusting and you not see flames?
Yeah.
Okay, great. Is that elephant actively combusting? So I'm going to ask you to give me an answer. And as a matter of fact, I'm going to ask you how sure, on a scale of 0 to 100%, how sure are you that that elephant is not combusting? What are you going to say?
Well, it's not combusting. I'm 99% sure.
99% sure. Okay, now I'm going to say, hey, there's a giraffe in another room that you cannot see, and there's some pyromaniacs running around. Is the giraffe on fire?
Possibly. Quite possibly.
So what number would you give that?
How many pyromaniacs are we talking?
How confident am I that it's not on fire?
As a matter of fact, that's a good... Yeah. How?
I would probably be, I don't know,
You have-
5% confident it's not on fire.
Okay. Now the doors open, you see the giraffe, and the giraffe just looks like this giraffe right here, no visible flame. Now how confident are you?
95%.
So what my friend CJ here, my fellow East Texas, I was trying not to say redneck, but that's really the only word that works.
Oh, yeah.
So it works for us.
I mean,
So
just say Cleveland and Finette, and people can look
it up and go,
figure out.
Jarvis was
talking
right,
Ohio.
rednecks. Not Ohio. So what you did is you had a pre-test probability, and then you ran some sort of test. You got some additional information.
something.
You learned something, and now you have a post-test probability. All right.
Okay.
Do you CAT scan every patient that comes into your ER with chest pain and shortness of breath to see if they have pulmonary embolism?
Of course not.
Of course not. Now, if you have someone on birth control with cancer who just flew back from Europe after having surgery on their fractured femur, and they suddenly developed hemoptysis, tachycardia, hypoxia, pleuritic chest pain, and their oxygen saturation is 40, would you... Let's make the oxygen saturation 85, so they would survive the trip to the CAT scan. Would you get a CAT scan on them?
Yeah, of course. Absolutely. They're getting a CTA because I am a real doctor, Dr. Crowe. I just want you to know that.
Wow.
Since
A real
you had to,
Damn.
you had to break down the jelly bean thing. I'm just feeling
That's
a little...
not what Sheldon says.
feel-
He's glad that you have that trade to fall back on.
Oh, I will say that the PhDs had the term doctor before we did, so we borrowed it.
I mean, lawyers are doctors too.
Oh, but are they? Let's discuss. So
On a different episode.
you're on the other hand, if I say, "Oh, Al, I just had some chest pain and shortness of breath," is it possible that I have a PE? I mean, anything's possible,
of
right?
course it's
But
possible.
a D-dimer might be useful for me. So D-dimers are the classic example of something you have to think about pre-test probability of. And anything we're doing that asks you for your pre-test probability and then applies some sort of test that has a known likelihood ratio and gives you a posterior probability, that's Bayesian analysis. How did I do with that?
Okay.
I think that what we're trying to say here is Bayesian analysis is a gray world. They recognize that the world is gray. Frequentists say the world is
it's
either...
recognized gray. It's that they take their learning into account in their next prediction.
Well, fair enough, but if you were to look at, say, this paper, which I promise we will do at some point,
There's a
what
paper?
the outcome of this paper is the probability that ketamine is better than etomidate. So it's not 100% or 0, it's somewhere in between. All right, so that's a Bayesian analysis. So when we said that this is a systematic review and meta-analysis. They're using a Bayesian analysis as opposed to a frequentist. Now, when we were talking about the giraffe and the elephant and the jelly beans and the pulmonary emboli, we were saying, so what is your initial guess, which is the word that drives the frequentist bongo ape shit crazy. What we're talking about is your prior or your pretest probability. Any analysis, as I understand it, is you have to start from what your prior is. In this, they said, you know what? We're going to start with the assumption that there is no difference in mortality between etomidate and ketamine, because most of the literature has, with frequentist analysis, haven't come up with a difference. And they said, what we're going to do is look at the mean, in other words, the point estimate from all these papers, and we think it's going to be 0. The absolute risk reduction will be 0. And we'll even go, for reasons that are beyond me, to say the 95% confidence interval is between 0.25 and 4 for a risk ratio. We know 1 is the point of no difference. That would be statistically
except for it's not a confidence interval; it's a credibility interval.
Yeah, fair point. A distinction that I'm going to have you back on in the future to figure out: is this a difference that matters? No, this is like what is the ATET? The average treatment among the treated. There we go.
That does matter.
Yeah,
we can have a show about that.
I will have to, because I'm not sure I understand it. And they calculated using this Bayes stuff.
Magic.
2 things. They said, what's the probability that, given all of this data, that there is any mortality advantage to ketamine? And then they ran it again and said, what is the probability that there is 1% or greater mortality advantage with ketamine? So that's what they did. All good papers. We like to have some sensitivity analyses in. A sensitivity analysis just says, well, you know what, maybe would give different results and therefore weaker results, less confidence, if we ran it a different way. They did 3 of these. One was this thing called a trial sequential analysis, and I am so going to ask you what the hell that is, because for me, TSA is somebody that slows my progress to the airplane. They also did it looking only at RCTs, and then they did one saying, we're going to exclude anything that had a high risk of bias. And did they get the same result? So you want to tell me what the hell a TSA is here?
Well, not unlike TSA. They do slow your progress towards a conclusion. So it is a method for looking at meta-analyses that takes into account things like the sample size of the studies that were used. And if it was a couple of really small studies, it'll penalize the estimate for that so that we have less certainty and we're less likely to be able to draw a conclusion one way or another. So not unlike TSA.
Yeah. Does this man have a weapon, or does he have a shoe or some shampoo that might go boom? Well, let's look at the PICO question. We said what the methods are. The population for this is all adults 18 or over, intubated in an in any study, including pre-hospital studies. Most of these were in hospital. ER, ICU. The only patients they excluded were pediatrics, cardiac arrest. You're being intubated because of cardiac arrest, and OR patients. Their intervention, the way they did the search, was ketamine of any dose, and then the comparator was anything not spelled ketamine. So midazolam, propofol, etomidate, anything, bonk over the head, raw dog intubation. So their outcome was all-cause mortality. Now, they had some secondary outcomes we'll go over, but I think we're really focused on outcomes here, on mortality. So when they did the paper, they initially started, this is their systematic review. As my friend Remle has taught me, when you describe your results, it needs to be a funnel. Starting at the top, work your way down to what your population is. They started and they found something that is going to need me to put my glasses on. 2,800 records of different papers. They filtered these things out. They said, well, that's not an RCT. That didn't have propensity matching. That's a case review. That's not comparing to ketamine. And they ended up with 55 papers. They read through all of those. They excluded 47, ending up with 8 papers to use in this RCT. So going from 2,868 potential papers, they found 8, which,
for meta-analysis,
as it turns out, is not all that unusual. These 8, there were 7 RCTs and 1 propensity-matched cohort analysis, and they included a ton of patients. So it's about 3,000 patients, 2,978 patients. All right. Overall, I'll just tell you what the results were. If they're asking the question, is there any benefit? And I should tell you this. There were no papers that included ketamine compared to midazolam or ketamine compared to propofol. Right. So this is, for all practical purposes, analysis of ketamine and etomidate. The range of ketamine doses was basically 1 to 2 milligrams per kilogram, and there were some different etomidate doses, but they're all essentially what we would expect. So somewhere around 0.2, 0.3 milligrams per kilogram.
Wasn't there a ketamine plus propofol?
There was one, you're right, that did 0.5 milligrams per kilogram of ketamine plus propofol titrated to effect. And I don't remember what their propofol dose was. Probably 100, somewhere in there, 50 something. All right, so what they found is they're overall using a neutral pretest, meaning it's 50-50, we don't know. They found on the back end of the analysis there's an 83.2% chance that ketamine has a mortality benefit. Mm-hmm. They said, well, what if we reran this and didn't ask if there's any mortality benefit, but only if there is a mortality benefit greater than 1%. That was 62%.
Yep.
All right. So
I think this is the probability of survival benefit is not all that different than a p-value in frequentist. Okay. It doesn't tell us anything about the size of the effect. It just tells us whether or not we should believe the effect. Now, the size of the effect is in the risk ratio, which is the same as in frequentist. So the risk ratio here was a 0.93, which 1 minus 0.93, a 7% reduction in mortality. So it's already pretty small, but now the credibility interval goes 0.79 to 1.08. Now, if that was a confidence interval and a regular risk ratio from frequentist statistics, what would we say?
It
crosses 1.
It crosses 1. It's not,
and it's not a huge effect anyway. 7%. Maybe we argue that's important. Maybe it's not.
They argued 1% was important.
So that's fair.
Out of millions.
Out of millions, perhaps, yes. And we can think about things like number needed to treat, whatever we want. But in frequentist, the difference is here we would have called this null, not important, no result. Here they say, okay, but not all of the tail of that confidence interval is touching 1. It's not centered. It's actually off in the direction of favoring ketamine. And so that's how it's a skew. So that's why that probability of survival benefit means, all right, it's 83% likely that this thing actually does favor ketamine in the way that the risk ratio is showing.
So why? So it's not a confidence interval? You're not going to talk about it this time. But
what's the difference between
when I looked at it, I was like, okay,
it's not
significant. Then,
it's interpreted. It's just that. It's that you don't interpret it as significant or not significant. It's still this interval where 95% likely that the true number of jelly beans lies within this.
Okay.
So it's not totally unlike it in frequentist, except for that we don't call it no good if the number crosses 1. We just say, all right, well, how sure are we that the number is off to the left or off to the right of 1? We're 83% sure that the number's to the left.
We being Bayesians.
We being the Bayesians. But the interesting part of this one is if you go to their supplementary material in their sensitivity analyses, they did a frequentist. Guess what they got as their risk ratio in the frequentist? It was 0.93. But why? Because their prior, that guess that they had before, was neutral. It's looking at the jelly beans for the first time. It's your random guess. So these two analyses were actually pretty much the same.
And here's where the frequentists say the Bayesians are stoned. So all of your analysis, what comes out the back end, is based completely on what your guess is. Your guess can be different than mine. So this is all a denying reality exists. That's what the frequentist would say. Fisher somewhere is going, you people are smoking crack. You've been up on your thing, contemplating your navel, getting high. You and Steve Jobs up there.
These are harsh words from Fisher. I didn't know that was his personality. All right.
Maybe not. All right. So
what about Pearson and Naiman? How'd they feel?
I have no idea who those two people are.
Okay.
Was Pearson the asshole? Or was Fisher the asshole?
Fisher
was the asshole. All right.
The books would suggest. I hope they write about me in this way.
I will have to say that everything I know about statistics did not come from the 3 stats classes I took. I didn't learn a damn thing in any of those. It comes from her sending me books and teaching me things. Everything I know about Bayes was, God, what was the name of that?
The Theory
book?
That Would Not
The
Die.
Theory That Would Not Die. I think I've plugged that book on this.
It's a good book. It's an interesting read for people who want to hear about how statisticians used to hang out together.
It's
awesome.
It's a great book. It really is. She's a great storyteller. Really good book. The other one was the history that you sent me. Oh no, I sent that to you.
That was Tasting Tea.
Yes,
that was a good
The
one.
Lady Tasting Tea. Great book, CJ. You should read that one.
Well,
It is
maybe
about
I
a
will.
lady that tastes tea.
It is, and also a good storyteller. Okay, so to cut this off, we need to go see the EMS fellows give the research. I think the bottom line, here's the summary of this paper, which I think is a reasonable summary. This Bayesian meta-analysis found a moderate probability that induction with ketamine compared to etomidate for tracheal intubation was associated with improved survival in critically ill patients. CJ, I got to ask you, now that we've had this fascinating discussion about what drug to use for our clinical scenario, are you more likely or less likely to tell your paramedics to use ketamine instead of, say, etomidate?
Well,
pretending they have so
yeah. So I guess that's the question, right?
Yeah.
So, knowing what I know about Bayesian meta-analysis, which is probably similar to what I knew before this podcast,
ouch,
I would say that
I don't think our jelly bean analogies worked.
Yeah,
Ask
I would
ChatGPT
say,
for an update.
yeah, even ChatGPT can't help me. I would say, yeah, it seems like we're trending towards ketamine is being the correct induction/sedation agent.
That was a very Bayesian answer.
Yeah.
The frequentist would have been the same.
Yeah. And I'll tell you my answer, because I love science that agrees with my perspective. So my prior is that ketamine is clearly the drug to use, and it ain't because of that adrenal suppression, because I'm not worried about that. I think ketamine's the drug to use, and therefore this paper absolutely increased my level of certainty. Now, if it had said the opposite, I would have found some serious flaws in this paper.
Like you do.
Like I do. Awesome. Guys, thank you all very much. Remle, thank you for joining us one more time, straightening this stuff out for us. CJ, thank you for joining the pod.
Thank you for having me. I just want to say, before I get the PhD cabal after me, my comment about a real doctor was in respect to Dr. Crowe's PhD student asked if I was a real doctor one time. That was the
well, yeah, but you did deserve that. Just to be clear, you deserve that.
You were.
That was absolutely nothing to do with PhD EMS researchers.
So
I have one that works 3 offices down the hall, and I really like him. I'm probably going to go have a beer with him right now.
Yeah,
so I just want to say,
thanks for setting the record straight.
Shout out to the PhD EMS researchers. Y'all are awesome, amazing.
Before you got to tell the story about, it was Atlanta, right?
It was in Atlanta.
It was Atlanta.
Is this
you
a story
tell
we want to tell?
It is. It is. But I also have to
look at the
point
time.
out that the only person whose credentials he questioned was the only woman on this group.
Ooh. Thanks, CJ.
What are you talking about? What's happening?
She's not going to take the bait.
I'm not.
All right, so tell the story. What's going on in Atlanta?
In Atlanta.
There we were.
Hungry.
Very
looking for
hungry.
some food. Somebody pulls out their phone and finds Indian food. Sounds delicious. Let's
Yum.
go.
Do it.
Little do we know, there's approximately 2 booths in there that fit maybe half of us.
Yeah.
Great. So then
we have to sit outside.
we did have to sit
Do you know
outside,
they
and
don't
maybe
call
they
it
did that on
Indian food in
purpose.
London? They call it go out for curry.
Oh, well,
But what if you don't have
we
curry?
didn't order curry.
That's exactly what I asked, Cleveland. And I exactly. Everyone
Go
looked at me.
Indians.
Well, so there we were. They put us outside. Maybe they did have space for us, but there was a strategic initiative to put us outside on the curb in Atlanta.
They're
Bayesian
smart.
analysis
Said
says
They
these
looked
guys
at
are
us.
going to be
Also,
assholes.
That's a
they
problem.
looked at the jelly beans and
Yeah.
kicked us right out
Right
of the
out.
jar.
Smart
There
people.
we were on
and
the
then
curb.
we proved them,
We
explained
proved
why
them
they were correct.
Yes, 100%. So we're sitting there on the curb in Atlanta waiting for our not curry. And CJ gets an idea, and he said, hey, we're outside, right? So if we
Well,
buy some
we did need
beers-
to be pre-lubricated, and
Right.
God knows
Well,
we were.
We were. So CJ asked, we're outside, not in the restaurant. Is it cool if we acquire some beverages, of the beer variety?
Well, I still don't know their answer. I'm sure there was probably a
He
language
said,
barrier
okay.
or
He said, okay.
perfect.
He said, okay.
Perfect.
I'm not sure
he
you
said,
actually
okay.
waited before
I don't know if he waited for the answer,
your
but
dispatch.
the very kind waiter said, okay. And CJ pulls out his wallet, hands to Dr. Wampler, who is a PhD.
A real
Right down the
doctor.
hall from
A
you,
real
who
doctor.
you might have been discussing.
Hey, why don't you go get us some beers up there at that Walgreens CVS? Okay, great. Off he goes. Comes back with the beers. CJ is telling a story somewhere from East Texas. I don't know.
Our
And
people.
I've
You know it's true.
I've got a research intern with me who's very new to this space.
Oh my God, that boy was so naive.
So naive, but very new to
Very
the space.
great guy.
Hard worker, wonderful. We're there for research and really into it. CJ's telling an East Texas story, and he leans over to me very quietly, very just, hey, is that guy really a doctor? As far as we know.
And that
And
is the
that's
question that still has not been answered.
He didn't ask if you were a real doctor. He asked if you really were a doctor.
Any flavor doctor. He's,
Well, I feel I have to I'm a real doctor, so says the
You're
Texas
really
Medical
a real
Board.
doctor.
well, look, they licensed me, so we know they're not very discriminatory. That was the best time. Oh my God,
And the best meal. That was great.
It-
Researchers,
was good food.
researchers are fun.
Can be.
Power to the nerds. Awesome. Guys, thank you all for joining us. As always, I thank you for what you do, and I'm looking forward to seeing you on the next episode. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.